So good evening all. Welcome everyone to the IRIA Kerala PG case presentation series. But today, actually there is a slight difference. It is mock exam session. And this is going to be conducted in the association with Janombet. Towards this, I welcome Dr. Gomadi Subramaniam, President Kerala IRIA, Dr. Rijo Matthew, Secretary Kerala IRIA, and Dr. Ramesh Shanai, Program Coordinator. And today the session is being moderated by Dr. Avani Skandan, Senior Consultant Radiologist, Aster MIMS, Kottakkal, Kerala. And I welcome Dr. Avani, and also I welcome our faculty, Dr. Uma Maheshwari Reddy, Professor of Radiology, Narayana Medical College, Nellore, and Consultant Radiologist and Director, Clarity Scans, Nellore. Hearty welcome, Dr. Uma Maheshwari Reddy. And now over to Dr. Avani Skandan for the introduction of the faculty.
Good evening, everybody. So I'm very happy to be welcoming our faculty of today, Dr. Uma Maheshwari Reddy. He has an extensive portfolio to describe. He has done his visiting fellowship in neuro and abdominal imaging from Boston, Harvard University. He is the consultant radiologist and director at Clarity Scans. He's the associate professor in radiodiagnosis at NMCH Nellore. He has secured first rank in the MD entrance exam of Manipal University and did his MD from Kasturba Medical College, Manipal. He completed his visiting fellowship in neuro and abdominal imaging from Harvard University, like I mentioned earlier. He has done his EDIR with Diplomat of ICRIA in 2019, won prizes during post-graduation in 4 quiz programs, best being Radiology Review Course quiz program, which was held at CMC Vellore. He is a prolific researcher with 100 publications in national and international index journals till date. And he is the first and second author for 35 publications. He has contributed chapters for 4 textbooks. He has presented in various state and national conferences, presented research papers in national conference, and has given talks in various state level and regional CME programs. He is a reviewer for 3 index journals, including PubMed Index Journals of Neurosciences in Rural Practice. Presented 1 educational exhibit in RSNA 2015 in Chicago and educational exhibit in Austria, Vienna 2020. He is a passionate teacher, which we will see in the further session, with regular lectures, photo sessions, interactive sessions with students. He has mentored over 50 educational exhibits and poster presentations of residents. He is the Joint Secretary of Andhra Pradesh IRIA 2021. He is the editor of the YouTube channel Radiology Case Videos, which has currently 275 videos, and his fields of interest are neuroradiology, chest imaging, and abdominal imaging. So from the profile itself, we know that we have a very eminent speaker with us. And so over to you, Dr. Uma Maheshwari Reddy. I'm sure everybody is waiting to see the sessions. Yeah. And I'm so sorry. The students that will be with him today are Dr. Bhargav Reddy and Dr. Sushmita Sri. So I welcome you also to the session. And over to you.
Unmute, Uma.
Thanks very much, madam. I'm more towards crest faculty. I'm very flattered by your intro. Nobody has read my intro in such an elaborate of late. Gomati madam, once again, thank you. Venu sir, thank you. Ramesh sir again, and Rijo sir. I'm almost like a family to all of them, and Amel sir. So second thing is like recent passion is in MSK, right? Because I've explored a lot of horizons in neuro, and I've done a lot of publications. As I'm finding more interest in MSK, and madam is knocking my door regularly to present an MSK, which I'm finding it very overwhelming. Thank you very much for that intro, madam. Let me straight away go into my topic, mock exam, and Sudhir and Bhargav Reddy, and first case you take, Bhargav. I'm sharing my PPT.
Good evening, sir.
Bhargav, I'll show the image,
yes,
history,
sir.
Then you describe, then yes, you come to differential diagnosis, then to the diagnosis. Okay, yes. 1 long case followed by 5 spotters. So okay, that is 1 set for you. Followed by that, Sushmita will take the same.
Yes,
okay, sir. This is a history, brief history. Okay, yes, let me go straight away go into the case. Yeah,
Yes, sir.
you can describe it now.
Yes, sir. This is the X-ray knee AP view showing ill-defined areas of sclerosis in the metaphysis of distal femur with broad zone of transition and with speculated periosteal response and with osteoid matrix.
Okay, I'll go with the second radio,
Yes,
second
sir.
view. Yeah, other
Yes,
view. One view is no view in MSK.
Yes, sir.
Okay.
And this is the lateral view of knee showing the ill-defined radiodense lesion with broad zone of transition and with speculated periosteal response. And the lesion is on the posterior surface of the knee.
It is cortical, intramedullary.
Yes, sir.
Huh?
Yes, sir.
And
Both cortical, intramedullary, and
there is a posterior breach into
yes, sir.
Posterior
Posterior
joint.
soft tissue. Yes, sir.
Posterior, it's excellent.
Yes, sir.
Okay. Is what all the you have not mentioned what is metaphysis involved or not? Metadiaphysis and
Yes,
also epiphysis.
Epiphysis, yes,
Very
sir.
important. That
Yes,
is
sir.
one site, transition zone,
Yes, sir.
gauge, matrix,
Yes, sir.
periosteal reaction,
Soft tissue. Yes, sir.
stamps. Okay,
Yes,
this
sir.
is the mnemonic. You should describe these aspects. So you have
Yes,
done a good job. You should have
Yes, sir.
mentioned the epimetaphysis.
Yes, sir. Yes.
So anything else you want to add in this description? Anything you missed when you're dealing with you're dealing with a malignant lesion or a benign lesion?
Malignant, sir.
Malignant lesion.
Yes,
so
sir.
what do you look for in malignant lesions?
A broad zone of transition, sir.
So what is this now? This is a calcified
Soft
lymph
tissue. Yes, sir. Calcified lymph nodes.
lymph nodes.
Yes, sir.
Separately seen, right? It's
Yes, sir.
definitely in. So that is a soft tissue, not soft tissue, is separately seen. Okay.
Yes, sir.
Most of metastatic calcified lymph node.
Yes, sir. Yes.
Okay, sorry for that image. So I would like to give you some chest radiograph,
Yes, sir.
chest CT.
Yes, sir.
Okay, what you can appreciate?
So this is coronal CT of the chest showing some calcified lesions in the lung field, sir.
Yes.
They
Okay.
probably they're metastasis, sir.
Okay, this is
Yes.
again.
Yes, sir.
So based on this, you want to make a diagnosis of
Osteosarcomas.
Tell me the types of osteosarcoma which you know.
Sir, central osteosarcoma, juxtacortical osteosarcoma, or parasteal osteosarcoma, multicentric osteosarcoma, and secondary osteosarcomas.
Okay, is there any differential diagnosis in a 24-year-old male patient for this case? If not osteosarcoma, anything else you want to consider?
Sir,
So osteosarcoma has a bimodal peak, isn't it?
Yes, sir. Yes, sir.
Osteosarcoma has a bimodal peak, and
Yes, sir.
definitely osteoid matrix with a sunburst periosteal reaction.
Yes,
You
sir.
kept
Yes,
on
sir.
saying speculated. You could have
Yes,
called
sir.
it a sunburst,
Sunburst. Yes, sir.
sun ray type of periosteal reaction.
Yes, sir.
It's a type of a interrupted periosteal reaction.
Yes, sir.
Where there
Yes.
will be elevation of the periosteum, along with there will be a Codman triangle. The
Yes, sir.
elevated periosteal
Periosteal,
reaction
yes.
along with the soft tissue gives a typical Codman appearance.
Yes, sir.
So this is very classical of osteosarcoma.
Yes, sir.
Is there at least any differential you would like to consider? Any closest differential?
Sir, in post-trauma myositis ossificans.
No. Definitely not. Definitely not. You can't get such a extensive osteoid matrix and bone involvement in this.
Okay.
Even any tumors, I mean to say, like
Ewing's.
sometimes they come in late presentation of Ewing's.
Ewing's, sir.
That's what I was expecting.
Yes,
Late
sir.
presentation of Ewing's somewhere in 18, 19 years, and they will neglect it and they may present to you at around 24 years.
Yes,
That
sir.
is a possibility.
Yes.
And second thing which you would like to know, there are some rarer tumors, something like fibrosarcoma.
Yes,
So
sir.
something like rarer tumors can mimic like this.
Yes, sir.
And anything you want to add about metastasis of osteosarcoma? Anything? You said calcified mets.
Yes, sir.
Osteosarcoma, and what type of spread it does? What
Hematogenous spread, sir.
hematogenous spread will be there in osteosarcoma, isn't
Yes.
it?
Yes.
So chest invariably chest CT is a must before operation of a osteosarcoma.
Yes, sir.
Found a calcified mets. Are there any different types of metastasis happening in an osteosarcoma? Any different types of metastasis, you know, what any characteristic find, any characteristics. Sometimes it can present with a pneumothorax.
Yes, sir. Yes, sir. Spontaneous.
It's presenting with pneumothorax in a
Yes,
young person. You should always think about a osteosarcoma metastasis.
Yes.
Okay. So different. This is the CT screening is lung is the most common site of metastasis. CT screening
Yes.
is must. Top differential diagnosis, Ewing sarcoma.
sarcoma.
This is what I was mentioning.
Yes, sir.
Okay, they can be associated with some P53 gene mutation or Life-Armory or this Rothman-Thompson syndrome.
Yes.
So these are all important. So most histological finding is presence of osteoid matrix. So this is the classical sunray periosteal reaction. Let us go into the spotters. You know, I have 5 spotters for you.
Yes, sir.
So this is the history. 45-year-old male with sickle cell disease.
Yes,
This
sir.
is the radiograph. What do you want to describe? In a single, just short description. No need to describe in stamps.
Yes, sir.
What is
There
it?
is a subchondral sclerosis with some lucent areas in the
Okay. Very
tumoral
good.
head, sir.
So what
Snow
is this?
cap sign, sir.
Oh, yeah, this is a classical snow cap sign.
Yes, sir.
It's a case of
Avascular necrosis.
avascular necrosis of humeral head.
Yes, sir.
Okay. So this is a diffuse sclerosis of the endosteal bone, and
Yes,
there will be loss of CMD. So,
Yes.
so the projection is so much. See the sclerosis you can appreciate compared
Yes.
to this. Here,
Yes.
this is the lucent bone. This is the sclerosed bone. So in sickle cell disease, there will be trapping of the sickle cells in the smaller microvasculature, resulting in avascular necrosis, and
Yes.
this can occur.
Yes.
Okay. Football player.
Yes,
See
sir.
the radiograph. What you see?
Sir, there is a bony fragment in the lateral.
Okay, very
Yes,
good.
sir.
So you are able to
Lateral
appreciate
tuberous.
it. Okay. What can be? What is the any name given to it?
Seagon's fracture.
Right, sir. Why is it so important? Second
It's
fracture.
indirect sign of ACL tear, sir.
Yes, definitely. So second fracture is an indirect sign that they can be associated ACL rupture
Yes,
or
sir.
a tear in second. There is something called reverse second which can occur in the medial side also. That is also important.
Okay, sir.
14-year-old child with
Yes, sir.
pain and swelling in left knee.
There is well-defined expansile lytic lesion in the metaphysis of fibula, sir. It's aneurysmal bone cyst, sir.
Why straight away? Why you could briefly describe
Yes, sir. And
with thin septa.
yes, sir. Horizontal septa.
Metadiaphysis region.
Yes, sir.
Okay, and not extending into the epiphysis or a physeal plate.
Yes, sir.
Okay. There is no cortical breach or no periosteal reaction. No periosteal reaction is one feature of ABC. That one thing,
Yes,
relatively very rare having periosteal reaction in ABC.
Yes, sir.
Thin multiple septa is one thing we can always appreciate in an ABC. This is a fibular head metadiaphyseal ABC. What is a MR finding?
Fluid levels, sir.
In MRI, in ABC, you can find fluid levels.
Yes, sir.
So that is one important feature. You should always look at it. So you can appreciate the thin septa here very much.
Yes, sir.
So, parallel septa is again a feature
Yes, sir.
in ABC.
Yes, sir.
So this is eccentric location, but in our case it is central.
Yes, sir.
Lytic expansal. Can you tell me other differential diagnosis for a expansal lytic lesion?
GCT, sir.
Only one you want to tell. There is a mnemonic, right?
Yes.
Phagnomasia. So
Yes, sir. Phygnomasia.
yeah, you can recall some.
Yes. Enchondroma, sir. F fibrous.
Okay.
F fibrous cortical defect.
Very good.
Yes.
FCD or yeah.
In non-ossifying fibromas.
Non-ossifying fibroma, you said, yes. And also
Osteoblast.
osteoblastoma you can get.
Yes, sir.
Okay.
And
All these things you can remember once again, recollect once again. These
yes,
things will be asked in exams invariably. Okay.
okay.
Radiograph by radiograph, you go. What are you seeing here? The cervical radiograph.
Yes.
And this dorsal radiograph, what you are seeing?
Sir, there is beaking of
Very good. Very good.
central
Central breaking.
central beaking, sir.
Okay. There is definitely, these are almost spool shaped vertebra. No,
Yes,
there
sir.
are multiple
Yes,
vertebra.
sir.
Definitely abnormal. There is
Yes.
anterior beaking for sure.
Yes, sir.
So what are you seeing in metacarpals? So the pointed metacarpals.
Yes,
You are
yes, sir.
seeing. Okay. Oh,
Yes.
then what else you are seeing? So there is a
Long.
pelvis shape is also definitely abnormal. Okay.
Yes.
So this is a classical case of
More.
Marquez disease. There will
Yes.
be widening of metacarpals with proximal pointing,
Yes.
metafacial flaring in long bones,
Yes, sir.
and also anterior central vertebral beaking, which is called flame-shaped vertebra. They can also be associated coxa-valga deformity.
Yes, sir.
That is about Marquez disease. You
Yes.
remember it? Read about all those mucopolysaccharides.
Yes, sir.
We're coming to first round, last quarter for you.
Yes, sir.
17-year-old severe pain during night, taking NSAIDs,
Yes, sir.
doctor NSAIDs. This
Yes,
is
sir.
a scan showing red arrow, showing something.
Yes.
What is the diagnosis? What do you want to put it
Sir,
at?
there is a central round lucency with surrounding sclerosis, sir,
Yeah,
in the anterior surface of tibia, sir.
anterior cortex of tibia.
Anterior cortex of tibia, sir. Is osteoid osteoma, sir.
Osteoid osteoma is a classical diagnosis. What you are seeing is a central
Nidus, central
nidus.
nidus.
Why is nidus so painful? It is it has a tiny unmyelinated terminal nerve endings.
Yes,
So
sir.
that is why extremely painful, debilitating. Patient will skip schools, or like they will have a very bad pain worsening on night, relieved by NSAIDs. This is the
Yes.
classical history. As a radiologist, you want to treat it, you can treat it.
Radio frequency ablation, sir.
Yes, that is one famous question they would like to ask. You put a probe in the nidus, burn it with 0.3 joules, and nidus completely disappears. And on-table relief is also documented in case of osteoid osteoma.
Yes.
So this is a relatively easier place for surgery actually, but sometimes there will be a femoral metaphyseal neck osteoid osteoma, or like you can have a osteochondroma of a foot. All those things are relatively difficult locations, calcaneal and all. So there you can have a RF radio frequency ablation as a very good role.
Yes.
So this is a sclerosis. There will be extensive sclerosis and some continuous periosteal reaction in cases
Yes.
of osteoid.
Yes.
Okay, so
Yes, sir.
this is the theory about osteoid. So you can central sclerotic focus you can identify.
Yes.
If, so these are the. So I already discussed about it. So Sushmita, are you okay? Are you ready? Bhargav, you can switch off your video. Let us go to the long case.
Hello, sir.
45-year-old female. This is the wrist radiograph. What are your findings?
X-ray APV of, sir, am I audible, sir?
Yeah, you are audible. Yeah.
X-ray APV of bilateral wrist
Left and right. Yeah.
showing erosions, increased density, increased attenuation, that is sclerosis of the distal radius and the ulna, and also the carpal bones, scaphoid. With a sclerotic lining there, with
Yeah.
reduced joint space.
Yeah. So the predominant finding here is loss of intercarpal joint space. First finding is here definitely there is all the carpal bones appear fused. Okay. Definitely there are erosions. What you said is absolutely right. There are erosions here. So this is the erosions. These have occurred in the. These are not central erosion. These have occurred in the bare area.
Metacarpal.
So what joint is?
Metacarpal joint.
So metacarpal joints. Carpometacarpal joints. You have the Erosion started definitely. So these are the other radiographs. So you have some working diagnosis at wrist radiograph level.
So,
Any differentials you want to? Erosions you said, joint space narrowing you said,
like arthritic features,
definitely arthritis. Why? Because relatively the
uniform joint space loss, we can say
osteopenia.
rheumatoid.
Osteopenia, relatively bone density is well preserved. So seeing this again, can you add up? For example, let's describe the foot radiograph.
Foot radiograph, left foot AP view showing the metatarsophalangeal joints.
Okay.
There are subluxation and little radial
There is
deviation of
soft tissue, isn't it? And there is definite angulation also. You're able to see the angulation.
and osteopenia.
Yeah, there's something called windswept deformity. So such deformities are also seen here. So here the erosions are more appreciable actually in these areas rather than there is osteopenia is evident here in this case. Okay, relatively.
Yes.
Anything in the sacroiliac joint radiograph? The upper one?
SI joints.
Subtle sclerosis. There is
Yeah.
definite subtle sclerosis you are able to appreciate here. Okay, and why chest radiograph has been given?
Nodules.
So what is chest radiograph showing? What is the pattern you are seeing in chest radiograph here?
The right lung parenchyma showing subtle haziness.
So you are seeing
Nodules.
reticulonodular opacities. So patient in if you have an arthritis, your working diagnosis was arthritis. So you want to narrow down your arthritis diagnosis after seeing so many X-rays. Sacroiliac joint sclerosis, deformities in the foot. There is
Rheumatoid arthritis.
yeah, definitely a possibility of rheumatoid arthritis. In rheumatoid, you get a usual interstitial pneumonia pattern of in bilateral lower lobes. So the same patient shoulder, what you are seeing here?
Joint effusion with irregularities of
Irregular erosion.
humeral head.
Also, you are able to see the
And subchondral cyst.
synovial thickening is predominant. Joint effusion is with debris. Definite debris is seen. And also some cuff related tears and all you have developed, So this is the patient has developed. So these are all the findings. So hand and foot are the earliest. So dips are generally rarely involved. Distal interphalangeal joints are rarely involved. So the main important things are MCPs, proximal interstitial joints are very important. So then it starts monoarticular and it goes into polyarticular phase, like in our case, what you saw. So all these deformities you can get, hitchhiker's thumb, Botnay's deformity, where there will be in Botnay's deformity, there will be hyperflexion of phalanx and also hyperextension of dip. So these are all the, you can also get swan neck deformity. So deformities are important. So predominantly when you get a case of rheumatoid arthritis, what you should see, look for, like, first thing is in a relatively young female with some history of joint pains will be given to you. Then you should always look at the joint spaces first of all. Then you should see the osteopenia. It is generally osteopenia. Then you can see the erosions. Erosions start earlier in the, so this is rheumatoid shoulder. So erosions will be starting in the bare area.
Aspect of the MCPs.
Yes. How do they progress? Later they go, though they involve the central areas. Then ultimately, even in rheumatoid, you can get penicillin cup deformity ultimately. So looking, and also joints, if other images are provided, you can see for erosions of rheumatoid. Okay, this is about the long case. Any other differentials you want to give in this case? You straight away cracked it as rheumatoid.
Joints.
Any close differential diagnosis? Younger female, you should always think about JRA, epiphyseal non-fused, or like 16, 17-year-old juvenile rheumatoid arthritis you can have. So erosive osteoarthritis is one thing which is common. but definitely it won't present with ILD. The erosion pattern will be completely different. Gulving
There
type.
is irregular joints.
Yeah, and predominantly gulving type of erosions you'll get in erosive osteoarthritis. This case unusual in wrist is there is preserved joint mineral density, which is unusual in rheumatoid. Normally you get a lot of osteopenia. This is about the rheumatoid arthritis, which you cracked it nicely. Okay, this is the history. Okay, large mass over the right knee. Pain was increasing on standing and on the descending on the stairs. There was fall.
Okay, sir. Double PCL signs.
Okay,
It is
you're seeing the double PCL.
buckle handle pair of the medial meniscus.
Very good, very good. So this medial meniscus, which was supposed to be here, has migrated, and is the bucket handle tear occurs in even lateral meniscus tear or only medial meniscus tear?
Medial
10 times more frequent with medial meniscus tear. So this is 10 times more common medially rather than laterally. So this is the classical bucket handle tear, the meniscus which is flipped and it is lying in the intercondylar notch. Football repetitive trauma to the knee. Okay, 14-year-old boy. So this is the CT scan. What you are seeing?
Osgood slab.
Yes, definitely there is a
Particular tendon inferior aspect at the tibial tuberosity.
joint. There is definite fragmentation. So fragmentation is seen here. So this is a case of Osgood-Schatter's disease. So this is the tibial apophysis which has been fragmented. Ultrasound has a very good role in identifying them. You can see the patellar tendinosis, fibrous. There will be fracture, and you can document it very well. This is a classical case of Osgood-Schatter's disease. Traction. This is secondary to traction apophysitis. No history, straightforward case. Hip joint X-ray.
Slipped SCF, slipped cap.
Left side, what side? Left side, yeah. So the left femoral epiphysis, if you carefully see, it's definitely grossly displaced. Gradings also, it's a severe grade. Generally, in a subtle cases, we may need a frog leg view or anything. So this is a classical case of slipped capitofemoral epiphysis. So nothing much to discuss about it. It's a spotter. History: 32-year-old male patient with fever, cough, low back ache, stiffness of the toe. So these are the multiple coronal stir images. Can you describe the findings in case? You have marked.
Coronal T2 weighted images showing hello sir.
Yeah, tell me. Yeah, you are audible, Sushmita.
Okay. Hyperintensities in the vertebral joint, vertebral bodies, and in the right sacroiliac joints.
Yeah. Okay.
Multiple myeloma.
So what you are seeing is predominantly the lungs are showing multiple nodules, okay, and also you're able to see a soft tissue here in the right paratracheal region, and the vertebra are definitely not normal. If you carefully see, you're able to see the abscess here. Here you are seeing an abscess here, and there is a iliac lesion here. So this is a case of multifocal tuberculosis. So this is a case of multifocal coccygeology where there is involvement of vertebra. Carefully, no, you should not get, when there are multiple images, you should not hop onto each image. You should stick onto one image, try to see all the findings. So a coronal stir image is to represent either a metastatic disease or a multifocal disease. So you should try to find a multiple pathologies. You could have definitely picked up this bird nest sign in radiograph. You know, there will be like thoracoabdominal sign is been described for this. So you have the spondylodiscitis here, and also you can have you have a lesion here. So this is a proven case of tuberculosis with a involvement of body. So last spotter for you. Okay, pain in both knees, shoulders, wrist. This is the lateral radiograph. I'll give you the one of the best radiograph. Yeah.
Lateral aspect of knee joint with calcification CPPD.
Yes, this is a meniscal calcification. So very differential diagnosis are there for this. Whenever there is meniscal calcification, you should think about CPPD. Very rarely. Any other calcification, any reason for calcification within meniscus? Something called congenital meniscal ossicle. So meniscal ossicle is one thing which we can always see. So this is, however, this is a case of CPPD. Ultrasound can show you the crystals floating within the joint. Ultrasound is a good value in cases with the CPPD. And also you can definitely do sabotage, like you can needle the sheets of calcification so that patients get relieved of the pain. So that is an radiology role. Okay. So mainly menisci and TFCC, acetabular labrum, these are the commonest site, especially deposited in the hyaline cartilage. So this is again a idiopathic etiology. Okay, Bhargav.
Yes, sir.
Let's go to long case 3.
Yes, sir. So this is coronal MR T2 weighted image
Okay.
showing hypointensity in the subchondral region of femoral head, sir.
Left femoral head. Yeah.
Yes, sir. Left femoral head, sir.
Anything else? This is the star image. Better appreciable. Post-COVID, this entity has become very common. Okay, this is a flattening of the
image. Yes, sir.
This
is a hypointensity in the subchondral. Yes, sir.
Okay, so there you could have mentioned definite flattening. So that is one thing. See, the round contour is maintained here, but definitely there is
Flattening of femoral.
yes. Here. So subchondral collapse. Which stage you would like to give according to Fichet-Arlet calcification?
Yes, sir.
Which one? What stage is it?
Third.
Yes, definitely. Third stage it is. There is also metaphyseal edema. However, there are no associated acetabular changes.
Yes, sir.
So right hip is normal according to you. Whenever you see avian, is it a unilateral pathology or bilateral generally?
Mostly bilateral.
So here also there is a geographic defect here.
Yes, sir.
So it is evident. Right. No, it's not just so you want to call it as 2 or 1?
2, sir.
Yes, when there is a geographic defect and of a you should always think about 2. So right grade 2. So any treatment differences in both of these?
Yes, sir.
Yeah, what do you know? What treatment they give for the right side and what treatment they give for the left side? So right side they can try core decompression.
Yes,
core
sir.
decompression they can try because they try to salvage the hip still.
Yes.
However, this is almost a hemi replacement stage.
Yes.
Almost hip. That is one thing we should always keep in mind. So 2 to 3, there is a lot of change in the diagnosis.
Yes, sir.
So identified in the subchondral collapse is one important role of imaging in avian. So
Yes.
this is From especially steroid decathlon or dexamethasone has been known to cause notoriously avian, and post-COVID there's so many avian cases coming.
Yes, sir.
You should know in and out about avian. So this is the Pickett-Arlett classification which is been done. So late stages there will be collapse and osteoarthritis.
Yes, sir.
Fourth stage is osteoarthritis.
Yes.
Earlier Pickett-Arlett was predominantly radiograph.
Yes,
Now we
sir.
have extended it to MRI. So stage 1 there will be only marrow edema.
Yes, sir.
So 2 there will be geographic defect, double density line or rim sign.
Rim sign, yes.
Crescent sign along eventual cortical collapse is seen in case of stage 3.
Yes.
In stage you can see secondary degenerative changes.
Yes.
Let's go into the spotter.
Yes.
Road traffic accident.
Yes.
There is a fluctuant swelling.
Yes.
The medial aspect. What are you seeing?
Sir, coronal stir hyperintensity in the medial aspect of it's a patellar.
No. You are going in wrong path. So this is actually secondary to shearing force. You know,
Yes.
this is secondary shearing force, and it's a subcutaneous injury.
Yes.
This is again happening in the subcutaneous plane.
Yes.
So there will be shearing force between the skin and the subcutaneous tissues, resulting in a moral Laval lesion. So no, it's commoner in hip joint.
Yes.
Ultrasound is enough to pick up this entity. Then comes the knee joint. You know, whenever there is a subcutaneous collection, you should always think about moral Laval lesion. This is classification given to it.
Yes.
Some earlier phase it looks like seroma. Our case goes into 2 or 3 mostly because it's more of a chronic organized hematoma. So that is a case of moral Laval lesion.
Yes.
Shearing injury, subcutaneous plane. So happening thing in MSK, they treat it differently compared to the capsular extended joint effusion.
Yes.
So that is one important thing. 6-year-old with a hip pain.
Yes, sir. This is frog-leg view of pelvis with bilateral hips. Left.
Left is abnormal, right is abnormal. Which is abnormal? So radiographs, you need more practice, you know, finding subtle findings relatively difficult. See the left epiphysis here and the epiphysis here, which is normal volume, which is increased volume, which is abnormal, which is normal.
Right side.
Right side is abnormal.
Normal.
No, there is definite sclerosis here. If you carefully see, there is definite sclerosis. So this is a case of Perthes disease on right side. So irregularity is there, sclerosis is there, flattening of the right femoral head is there.
Yes.
Practice more of radiographs. Look at the femoral heads. Look more Perthes lesions. SCFE, Perthes, these are all common adolescent diseases. So you should always identify the volume. Definitely, there is reduced volume on right side and sclerosis compared to the left side. So this is a case of Perthes disease on right side.
Fibrous cortical dysplasia.
I thought you will give that differential diagnosis, but if you carefully see, it's like hardly any mineral.
Osteogenesis.
Yes. This is a case of osteogenesis.
Is imperfect.
What is the deformity you are seeing here?
Shepherd crook deformity.
No, this is Shepherd crook. This is at the tibial diaphysis. This is called
Erlenmeyer
deformity you're seeing. So bowing of the tibia you're seeing. So this is a classical osteogenesis with diffuse osteopenia.
Yes.
Fractures are very common. These people, it's because of collagen deficiency. There are almost 10 types of osteogenesis imperfecta. If you're interested, you can go read about that. Okay. So fractures. This is the thing which I have told about osteogenesis imperfecta. Okay. Knee pain, swelling, limitation of range of movement.
Sir, synovial chondromatosis.
Yes, primary synovial chondromatosis is the most probable diagnosis. Multiple lucencies you are seeing and calcifications are seeing, and
Yes.
the joint cavity. There is osteoarthritis also associated with it.
Yes.
This is a primary synovial osteochondromasis because it's so extensively involved. Compared to osteoarthritis, the synovial osteochondromasis is more severe.
Yes.
That is how most probably it's a primary osteochondral, and it's straightforward. Nothing much to discuss about it. Okay, you can get in any joint, elbow, or like you can get in shoulder and all. So bag of sac appearance, or like there are a
Yes.
lot of signs described for it. Mass. You have got a lot of knee X-rays. Huh?
Yes, sir. So this is a AP view showing the bony fragment in the medial femoral. Yes.
Medial, adjacent to the medial femoral.
Medial
bone.
femoral. Yes.
What is it?
Pellegrini stida.
Yeah, this is a classical case of Pellegrini stida disease. So Pellegrini is a post-traumatic ossification followed by avulsion of MCL. You know, MCL will be avulsed and there will be post-traumatic ossification. So
Yes.
give a typical MCL ossification. This is case of Pellegrini stida disease. It's a spotter. Good job, Bhargav. All the best for
Yes,
your.
thank you, sir.
Let's go with Sushmita. We're going in. So it is an interesting case which I would like to show you. This is a radiograph. First, you describe the radiograph, what you are seeing.
X-ray AP view of the pelvis with bilateral hips, showing the increased bone density.
Where exactly?
The ischial regions and.
Would you say the bone density is increased here or here? Where exactly is it increased? Right side or left side?
Left side, sir.
Definitely left side bone density is increased. Yeah.
Both. Even there are few lytic lesions are also seen in the ileum, sir.
You're able to see some lucent lesions, no? So
Yes,
you're
sir.
seeing the increased density of the ischium, pubis, then you're able to see extending into the iliac wing. And you want to comment anything about the joint space?
It was narrowed.
Joint space is definitely narrowed. Okay, you are able to see some lucencies. So what are your differential diagnoses at this point?
So both blastic and lytic lesions are seen.
Okay.
Paget's disease and then mixed blastic and lytic mets.
That's very good differential. Very good differential. Lytic and mixed metastasis. Which disease can cause this?
Prostate cancer.
Prostate can cause, and also if female, breast carcinoma can cause mixed blastic and lytic metastasis. So the Paget's said no. What is the hallmark feature of Paget's disease in pelvis?
It's like pelvic brim signs, a thickened iliopectineal and ilioischial lines.
Examiner expects, no, you have to utter the words which are very classical. Thickening of iliopectineal line is what is important, you know. That's something you should be appreciating it. So other thing, what other line, any line?
Teardrop.
Teardrop. All these things are important. Okay. Okay. 1 minute. I have to just come back. See, what I'm trying to tell you is, again, the mixed sclerotic things are very well appreciated on a CT. Okay, here you're able to appreciate on CT. There is a definite, and what is the finding appreciated? Joint space, there is something called protrusio acetabuli. Protrusio acetabuli is the one finding which you should identify. So what are you seeing here in spine?
Spine.
Diagram is again showing mixed lytic sclerosis, and there is what vertebra they call?
In picture frame.
Picture frame vertebra. You are not picture frame. Predominantly, you should call it as ivory vertebra. No, they dense calcification. They look like almost ivory. What are the skull findings? Skull findings.
Osteoporosis circumstructure.
More predominantly, it is more of a, again you get thickened calvarium, and also you get a basilar invagination. In this case, it's not appreciable. And also, if there are fractures in Paget's disease, what fractures will you call them?
Banana fractures.
Yeah, banana fractures you call them in Paget's disease. So close differentials, as you mentioned already, osteoblastic metastasis, old age, Paget's disease. There will be associations with multi-system atrophy, brain findings can be there. So that's about Paget's disease. Okay, this is thickening from a borrowed illustration, thickening of the calvarium. So you get a vertebra, which is ivory vertebra. Dense sclerosis of the vertebra seen on radiograph is called ivory vertebra. Thickening of the trabecula give this picture. This is a case of Paget's disease. So that mixed lytic sclerotic images, they look like this in last phase of Paget's. What are the phases? Can you tell? First phase is?
First is osteoclastic predominance. Second is intermediate, both mixed blastic and clastic, and the third is sclerotic, followed by malignancy.
Yeah. So these are the early. There will be thin lytic phase. Then a later stage will be lytic sclerotic. Thickened trabeculae, thickened iliopectineal. These are the classical. So fibrous dysplasia sometimes can mimic polyostotic fibrous dysplasia. It looks like Paget's, very common. Treated malignancies and myeloma also can mimic a Paget's disease. Let's go to your set of 5 spotters. Elbow. This is one joint which I have not covered, so I'll put this. What you're seeing, what images are giving you? MRI approach the sequence, you get the diagnosis.
Axial T1 weighted T2 weighted MRI.
This is T2 or T1? How is the joint fusion? Black or white?
T1, sir.
This is T1 weight image.
T1.
Yeah.
And then sagittal fat set, sir.
Okay.
So it is hyperintense on T1 and is suppressing on fat set images. Lipoma.
This is T2. Okay. So this is a classical brachioradialis muscle intramuscular lipoma. So nothing much. No, this is about MR sequences rather than MSK or anything. So T1 hyperintense, fat site it's getting suppressed, and a lobulated lesion with thin septa. So straightforward case of brachioradialis lipoma. Okay. One joint again which I have not touched, all the for finishing sake.
Axial sections of wrist, and then coronal views showing multiple fluid levels in the lateral aspect of the lateral aspect.
Lateral aspect within any fluid levels.
Medial aspect of.
You are seeing this metacarpal. You are seeing this metacarpal. You are metacarpal.
At the 5th metacarpal.
Yeah, you are not able to describe it. Yeah.
Multiple fluid levels.
Okay. Okay.
Aneurysmal bone cyst.
So 5th metacarpal aneurysmal bone cyst is a differential diagnosis. Very rarely, sometimes even huge enchondromas, when they have a lot of septa, you can definitely have this picture. Okay, so this is a classical case of aneurysmal bone cyst of 5th metacarpal. Spotter of observation. Carefully, you can see pathology. Both knees have been given. Not able to identify the pathology. Next set of images shall I go?
The lateral aspect of femur, sir.
Okay, what you're seeing here?
Osteochondral defect is in the medial aspect of the femoral condyle.
What are any differentials you want to give? So the T1 weighted image, which you're seeing a clear lucency, and you could have appreciated bone marrow edema if it was a T2 based or a PDFS image. So this is a classical osteochondral defect. What all differentials you can consider? Subchondral insufficiency fracture. and SONC. No, the bigger form of subchondral insufficiency fracture is called SONC. So radiograph, you should definite sclerosis is seen, and also bone infarct. But definitely there will not be any cortical defect in bone infarct. So these are all the classical features of osteochondral defect. So this is definitely a spotter. You should be able to observe and pick it up. I'll give 2 images for this. Yeah, 1, 2.
The anterior aspect of sagittal sections of MRI with multiple fluid intensity lesions, meniscal cysts.
Yeah, definitely there is a meniscal tear in the anterior horn, which is leading into the giant meniscal cyst. So this is a case of sorry for that. Yeah, parameniscal cyst resulting in. So this is a giant parameniscal cyst secondary to meniscal tear. So coming to last case, this is a giant parameniscal cyst from a meniscal tear. This is from internet. Last case.
Mention of vertebral.
What signs you are seeing?
Quadrate cloth appearance.
Quadrate cloth, Jane bar appearance because of the linear trabeculae are clearly seen, and also spoke wheel pattern you are seeing in an axial image. So this is a coarse periosteal response leading to honeycomb striated radiating appearance in hemangiomas. Okay, thank you very much. You did well, Suchita. You have to, all of you should pick up more conventional findings. You know, you people are good in cross section nowadays. Only thing is, please go through convention a little more, see more radiograph. There are good books like Adam Greenspan, and which is a wonderful approach in orthopedics. Rather than going into joint imaging so early in your career, you should pick up more radiograph findings, because it all starts from radiograph. Then you have to upgrade yourself to MRI in MSK. Okay, and also practice USG. It helps very well in soft tissue lesions. And also the lesions, especially like, moral level lesion, which you have seen, for example, in the apophyseal traction apophysitis, all these things, ultrasound is very helpful, and especially neuropathologies. Even I don't believe that. I feel ultrasound and MR are almost equal in picking up in superficial neural pathologies. You should always do them, and you should always try to diagnose those conditions. Thank you very much once again for the opportunity, madam. Avni madam, Komti madam, are you online? Soumya?
Yes, good evening, doctor. Doctor, we have 2-3 questions there. So one is, sir, can you just tell how one should approach for sequences to diagnosis on MRI?
Always, yeah, 3 questions I could see. We should always go based on T1, T2. If it is joint pathology, PDFS, then gradient is must. With a radiograph with you before going into MRI. So this is the best way to approach an MSK MRI. First, you should have a T1, T2, PDFS, gradient sequences and varying planes. So certain joints have certain planes that you should go through thoroughly. For example, if you want to see SI joint pathology, a planning should be done exactly in a way that you can see the XI joints properly, so that your grading and scoring should be will be very good. For example, if you want to pick up a labral tear, so labral tears are seen in coronal and sagittal views very well compared to axial views. I'm talking about superior labrum. Compared when coming to inferior labral tears, you can pick it up very well on axial. So plane is important again in MSK along with the sequences. So that the question is like very difficult, maybe joint wise I can approach. I can tell you that goes in different class. So that is one thing I would like to answer. Next question is, if any new case comes regarding which we don't know anything, how one should approach the case. So that is coming to radiology basics. We have to have a radiograph, and then history, clinical history, then radiograph, then MRI. This is how we should go about it. So one of person needs doubts. I can share him the for him. He asked me the number of it. I'm giving it to him, so he can contact me freely whenever he's free. So this is again last question I already answered. Thank you, sir. Thank you.
It was wonderful session, Dr. Kumar. The way you approached, the way you discussed the questions, all are very, very good. Really, MSK is little tough, but still you made it so clear to everyone. It was really, really very nice. The resident should really learn how to approach to a MSK case. It was very well done by your residents also. They did very well. Thank you so much, Dr. Roma.
Thank you, Ramesh. Thanks once again. I'll see you again. Thank you.
Thank you. Avni, I think she has gone out of coverage, I think.
Okay, ma'am.
Yeah.
Thank you, Soumya.
Thank you all. So at this outset, I thank Dr. Uma Maheshwar Reddy for presenting such a wonderful mock session with their residents. On behalf of Kerala IRIA, I take this opportunity to thank you. I thank Dr. Venu, who was with us as our academic chairman. I thank Dr. Avani, Dr. Rijo, all the members of Kerala IRIA. I thank the tech team, Soumya, who is with us without any interruption. Thank you, one and all.